Welcome, everybody. Thanks of those of you who have joined very promptly. We'll be starting at midday, so just in a couple more minutes. And again, welcome to those of you who have joined us already. Please do start introducing yourselves in the chat, and we'll get going in another minute or so. Okay, we're gonna get going. So welcome everybody to this next webinar in our social prescribing link worker webinar series that we started in January here at NASP. It's really great to see so many of you here, some familiar and new names in the chat. So please do keep introducing yourself via there. We are gonna just take you through a little bit of housekeeping to start off with, and then we'll get into the main meat of the session. So please note that we are recording this webinar. Everybody that has registered for this webinar will be sent the slides and the link to the recording as well. So it will also be on NASP website so that you can share it with as many colleagues as you feel would find this webinar interesting once we publish that. As usual with any of our webinars, we use the chat function to network and the Q&A function to ask any questions. So we will have time at the end where we will be putting questions to the expert speakers that we've got on our panel today. So please do use the Q&A function for that to make sure that we get to those. As I say, use the chat function to introduce yourself, as I can see so many people are doing already, and to network with one another. It's also the place to raise if you've got any technical issues, and we've got our NASP team working in the background to support with those things. So do raise if you're having any issues in the chat function there. And also just to note that closed captions are available and they can be turned on just at that bottom bar that you should hopefully be able to see on your screen. And that's where you'll also see that chat function that I mentioned and the Q&A function as well. So if we can go to the next slide, please. So yes, so I probably should introduce myself. So I'm Monica Bolton. I work for NASP as the strategic lead for neighbourhood health and healthcare integration. And we've got some really wonderful speakers with us today. So first we're going to be hearing from Tracy, who is a director at Skills Based First Aid. We're then going to be hearing from Sarah, who works for Nottingham Community and Voluntary Service. And then Ashwini, who is a social prescriber and a very valued member of our Link Worker Advisory Group here at NASP as well. So this session is focused on mental health and how that links with the role of social prescribing link workers. We know that link workers are in a position to notice perhaps some of those early signs of mental health difficulties, to provide compassionate, holistic, person-centered, non-clinical support, and are obviously perfectly placed to connect people with the resources, the assets, the opportunities that are in the community to support somebody with their mental health. However, we know that sometimes some of those sort of role and remit can feel a little bit blurred, and that is why we wanted to put on this webinar today, so that you can feel more confident in how to identify people's mental health needs, what those presentations might look like, be aware of and be able to explain what the role of social prescribing link workers is when people are struggling with mental health issues, but also how to connect in and work with other professionals in that way. We also wanted to showcase some of the work that was done through the Green Social Prescribing Programme around different mental health levels to really enable those very safe and effective referral pathways into those all important community assets. And then importantly, thinking about how to escalate some of those concerns that you have. So understanding what those other roles are, as I say, understanding what those kind of needs and presentations might look like. So that's the session. That's what we're going to hopefully be able to cover today. As I say, please do put questions in the chat so that we can keep this conversational and make sure that it's as useful for you guys as possible. And we've got, as I say, some really wonderful speakers who are truly experts, and I'm really looking forward to hearing from each of them today. So without further ado, I'm going to hand over to Tracy. So Tracy is a specialist facilitator in emotional well-being and resilience, and she helps workplaces and individuals build confidence in supporting mental health through practical training. So Tracy, over to you.
Thank you. Thank you, Monica. So yeah, good afternoon, everybody. I'm Tracy Dangerfield, and hopefully I'm going to set the scene and for covering all those wonderful things that Monica shared in the introduction. So what I'm going to cover is we'll look at what we mean by the term mental health, what we mean by a mental health problem, or as Monica said, a mental health difficulty might be language that you use, and then the alarm bells for declining well-being, and then most importantly, a short action plan. So quite a lot there to cover in like 20 minutes. So, I mean, I do naturally speak fast anyway, so that should help me. But if you're going through any of my presentation, you think, oh, there's some really good detail on there. Don't worry, because you're going to get a copy of these slides afterwards. And like Monica said, it is being recorded. Just a quick kind of note here on the slide about this. This is all about training purposes only. And the briefing, it might include difficult or potentially triggering topics around mental ill health. My intention isn't to trigger you. It's just provided for training purposes, but it should never substitute for professional advice. So please consult your GP in any way if you're concerned about your physical or your mental health, particularly concerning any symptoms that might require diagnosis or medical attention. What you'll find as well with the way we work at Schoolbase is we work further away from the medical model and looking at more social ways we can help people, which I think ties nicely with the purpose of this webinar as well. So let's get started. So let's set the scene. On ordinary days, for ordinary people, life can change in a heartbeat. Imagine this. In a heartbeat, it's 3 o'clock in the morning. Your neighbour is frantically knocking on your door because they have just found their partner unconscious with empty bottles of alcohol and medication. You're sat in your regular weekly team meeting, and suddenly, in a heartbeat, a colleague is gasping for breath, trembling, and is in an overwhelming state of panic. Imagine you're down at the pub with your friend and they don't seem their usual self. You ask them if they're okay and they brush it off. You ask them again, and in a heartbeat, they start to sob uncontrollably, sharing that their child has recently been cutting themselves. Imagine being that neighbour, that colleague, or that friend. And now imagine how overwhelming and how scary that would be for them. And now imagine that you had absolutely no idea what to do. Maybe you've never done any mental wellbeing training, or maybe you let it go out of date. That's what's unthinkable to us at Schoolbase First Aid. And we're on a mission and to create what we call heroes on standby with our mental wellbeing training in the workplace and in the community. So we believe that no one should feel anything less than confident in dealing with an emergency. And even if from today, just spending 20 minutes with me, if you go away as a link worker feeling that little bit more confident and empowered to help somebody in need, then I think it's worth spending 20 minutes together. So imagine if you could step in with knowledge, courage, and confidence and make a real difference to that neighbour, that colleague or that friend at the pub. So we've all got times where we're called upon to be a hero, and what we mean by a hero at Skill Base, it's not about swooping in as the superhero and saving the day. It's about that inner feeling we feel, that empowerment to step in when it matters, even if it's subtly or if it's in a crisis. And we'll cover both those topics today. So let's get started then. So using the chat then, I'd like to hear, I mean, I might not be able to read all of them out because we've got fairly quite a few people on this, so I might have to spot read. But if you could just all maybe share in the chat, when you hear the term mental health, what does it mean to you? What comes to mind? What words come to mind? What phrases come to mind? And then just share them in the chat and then we can get a bit of a feel. So mental well-being. So low mood, stress, anxiety, someone's connecting adverse childhood experiences, low mood, thoughts of despair, emotions, feelings, anxiety. It can be positive or negative. Yeah, thank you, Tiff, for that. Emotions you're feeling, loneliness, stress, anxiety, PTSD. So some kind of medical names there, PTSD, post-traumatic stress disorder, that stands for. Um, Impacting our ability to function in day to day. Rachel, yeah, that's a good one. What else we got? Looking after our mental well-being and taking it just as seriously as our physical health. I mean, bonus points for that one, Monica. Absolutely. Mental health, psychological well-being, mental ill health, poorer psychological well-being. Mental, yeah. So Erin's there, spotted naming the difference there between what mental health means and what mental ill health mean. Totally ahead of the game there, which is really great to see. And other words we've got there, resilience. It might be that we're unable to cope with life as it is. So there's quite a good mix here in the chat. And I think, I mean, when I'd say even still like, even today it still exists, but not as much as it did, like say 6 years ago. When I'd asked this question in the workplace or in the community, quite often we tend to focus on the illness side of it. And actually the first thing is that mental health is part of our overall health, like some of you have said amazingly in the chat there. And then we've got a World Health Organization definition here of what we mean by mental health, and that is where someone's well-being, which every individual realizes their own potential, can work, can cope with the normal stresses of life, can work productively and fruitfully, and is able to make a contribution to their community. Mental health does not mean being ill, which I think lots of you captured amazingly in the chat there. So thank you for that. Sometimes, like with our physical health, our well-being, sometimes our levels of mental health and well-being can also decline, and mental ill health is common. And if you think about the common cold that we might experience, sometimes we might think of things like, "Oh, I'm either ill or I'm well," like kind of like black and white type thinking. But even if you think of physical health, if you're coming down with the flu or if you're coming down with the cold, there's within that week there'll be days where you feel a bit better and you can do certain things versus days where you're in bed with a fever. And it's just, it can be similar to how we might feel with our mental ill health. It can if we're experiencing mental ill health, it doesn't mean it's always unwell. There's peaks of well-being within that as well. So how common is mental ill health? You've probably heard of this statistic, maybe you haven't, but 1 in 4 people will experience a mental health problem each year. I think that's quite important, the each year bit, because sometimes people hear stats like 1 in 4 and we think in a lifetime, but this is every year. 1 in 5 people will have experienced a common mental health problem in the past week. And when I say a common mental health problem, it's things like anxiety, depression. I'd say stress. I think sometimes it's more accepted to say we're stressed, and we don't necessarily view it as a mental health problem or mental ill health. But if we're experiencing prolonged periods of stress, it can develop into mental ill health. 1 in 3 people with a long-term physical health problem will also have a mental health problem. I think we can all relate to that personally. You know, if we suddenly weren't able to physically drive a car, if you're a car driver, or if we're going through quite a severe physical health problem, it's going to have an impact on how we feel and how we cope, and all those things you were saying in the chat there about our mental health. So around 1 in 10 children have a mental health problem that could be diagnosed as a mental illness. And 3/4 of mental illness starts before the age of 18. Now, as a mum, that this slide kind of scares me a little bit. And the reason why we include things like this on adult-based courses is because at school-based, we don't want to create barriers to helping children and to helping adults. We're learning in mental health first aid, we're learning skills that are going to help us help other people open up, and whether that's your niece or your daughter or your son, versus talking to your colleagues at work. They're the same skills that we're tapping into. So 75% of people with a diagnosable mental illness receive no treatment at all. We won't go into why we think that might be because we won't have enough time, but generally that is down to the number one answer is stigma. And that adds to this slide as well. So 90% of employees in the UK in particular feel unable to disclose a mental health problem to their employer. And the reasons that typically come up are because it's judged as being weak, or we might not be considered for a promotion, or it might be that we'll be viewed or discriminated against because whether we'll be able to do our job or not. And so because there's still a lot of stigma around mental health, mental ill health, that stops us being open and honest about what we're actually experiencing. So I'm going to look at alarm bells now. So whilst someone's well-being, if someone's well-being is declining, the signs and the symptoms. So signs and symptoms for me is quite a clinical, like someone's experiencing this symptom or there's this sign. So we try to make it more accessible and say these are alarm bell. This is a bit like a just spotted, like that example at the beginning, you're at the pub with your friend, you spot that they're not the usual self. That's a bit of an alarm bell for us. But they can really vary and differ significantly from person to person. So what we've done is we've put some things together that there could be experiences that are more common, specifically around changes in our thoughts, changes in our feelings, changes in our behaviours, and then physical responses that we might see or experience in people. But the key thing with our mental wellbeing first aid skills is to get to know the people around us and know what's normal for them and what's different. And then that's really when we can go, oh, that doesn't seem like their usual self. I'm gonna step in and have a conversation. So like I said earlier about how we used to maybe think of ill health as being either well or ill, and there's actually this bit in between, even with our physical health. So let's explore that for our well-being. So it might be that we're in this kind of well zone. We cope normally with ups and downs. Maybe we're quite a calm and patient person. That doesn't mean if you're not a patient person that you're necessarily mentally unwell. So it's really important to get to know the people around you. And then you can see how it slides here down to a decline in ill health, where we've got an unable to cope or feeling a sense of doom, and extensive panic attacks or anxiety attacks. And then it might be that the person's describing feeling numb, not feeling anything. And that's where depression they might be experiencing. And then thinking about changes here in terms of, it might be that we've got a good sense of humour, we take things in our stride, maybe we're able to focus, and then how it slides into that yellow and that amber zone. So it might be that we're becoming, it's display sarcasm, but then it starts to become into an overly negative attitude, which actually isn't the normal for that person, and maybe they're becoming non-compliant. Or it might be that our thoughts are becoming more intrusive, maybe persistent intrusions, and then developing into suicidal thoughts. Or it might be that we can see it in terms of our focus and concentration because our thoughts are starting to feel disordered. And so, and that's in this red zone here. And then thinking about physically, we might be quite a sociable person. We might be present, not necessarily distracted, or we might be in a workplace capacity. We're performing really well. And then I think at this point, if I'm in the workplace as well, I'd always recommend intervening. Like if there has been a decrease in performance, or even here in the procrastination. And I don't know if you can see my mouse, so that's I was waving around it then. But yeah, so even if it's like it's some procrastination or there's decreased performance, if we do a wellness action plan instead of performance management plans, the outcome is so much more positive. So I'd really recommend that. Absenteeism and presenteeism is quite a jargony word. But it basically means that we're not at work because we're unwell. Stigma tends to tell us to either badge it under stress, or it might be that we're saying it's a physical health because actually we're starting to feel the physical impacts of mental ill health as well. Or presenteeism is where we're actually at work, but we're really not well enough to be at work. And And a lot of that is there's lots of statistics around that and the amount of working days that are lost. So there's a real kind of business case for doing more training around mental well-being in the workplace. Um, so thinking about physical changes, as it might be that we have changes in our sleep or our appetite or in our energy. So I know for me personally, my energy is quite important and they connect to sleep as well. If I've not had much sleep, it impacts how much energy I have. But if I'm starting to have a decline in ill health, it might be that I'm having trouble sleeping or maybe I'm sleeping too much. And then changes in my eating. And for me, I'm definitely an emotional eater if I'm going through a tough time. The last thing I want is a salad when I'm feeling stressed. So that shows me I'm in these zones and I need to, it's a real indicator for me. And then energy. So if I'm usually quite an energetic person. So if I'm not feeling energetic, then that's a sign. So these are the things we can be looking out for in ourselves and the people around us. And then there might be changes in how we use substances. So this slide isn't just about like illegal substances or anything like that. This is about anything that can kind of become addictive. So it might be addictive behaviors. For more recently, what I talk about a lot is addiction to our phones. So it might be that if we are feeling unwell, we might be trying to escape those thoughts, those negative thoughts, and we're doom scrolling on our phones. Or it might be that we're increasing our alcohol consumption or substances. And I'd put in there as well, like caffeine. Sometimes we might be having too much caffeine as well to kind of help us with some of those previous slides there, some of the signs that we'd spotted in somebody. So let's say we've spotted one of these signs or a few of these signs in ourselves or in a colleague or a friend. We need to think about ACT. So our ACT plan, the A stands for approach. We want to approach the person. So there's a few little kind of examples on here of how we might approach somebody. Biggest advice I'd say on this as well is always stick to facts because facts are our friends. If we start putting assumptions or our opinions in there, we're more likely to get people having to defend themselves. Whereas if we stick to facts, we can keep the conversation more curious and we can actually help them open up and build trust. There's this Ask Twice. I don't know if any of you, if you Googled this, the Ask Twice campaign. There's a really good campaign where it's talking about the psychology of, especially in the UK, we use "How are you" as a greeting, like literally this morning at school gate, taking my kids into school, often saying, "Hi, are you all right? You all right?" We're not actually saying, "Are you okay?" So asking twice when you say to them, but really though, "Are you okay?" A bit like that example at the beginning with a friend in the pub. The brain really hears the question then, and then they'll be able to tell you if they really are okay, if they're not okay. And if they're not okay, hearing that question can be a real kind of door opener to talking more about it. Um, so think about the kind of where and when you do it. Don't wait for the perfect time to start a conversation. It might be that you want to do it in person, but it doesn't have to be in person. It could be picking up the phone. It could be a message. It could be like this on a remote meeting. It could be going on a walk. I love walking meetings because it's less confrontational, sort of walking side by side. Chatting to somebody in the car is quite powerful because we're side by side and me and my husband usually have our deep and meaningful conversations when we're on a long journey because we're kind of stuck in the car together. And there's something about that sitting side by side. So think about where and when you start a conversation, but don't hesitate on starting it. If you spotted it, the more confident you get in just in having these and just becoming parts of your everyday conversations. So our C as part of the ACT plan stands for crisis. So the first thing we want to do is find out if the person's in crisis because that's going to determine where we go on our action plan. So what we mean by mental health crisis, it can mean different things, but it generally means that someone's health has worsened to a point where they need urgent help for professional services. A mental health emergency should always be taken as seriously as a physical health emergency. So they might include, so the key word here is might because it's different for each person, but severe influence of substances, severe self-harm, needing assistance. There might be a need for physical help, physical first aiders or medical help. There might be an extraordinarily anxious or panic attack. It might be their first panic attack. They might be experiencing paranoia, mania, psychosis. They're really jargony medical words, and we break that down in our training. But what that basically means is their reality is very different to the actual reality. So they'll be hearing or seeing or feeling things that are not actually there. And you would know that because they would come across really confused and disorientated. They might be experiencing suicidal thoughts, and it might be that you don't know that until you actually ask them the question as well. And it might be that they're acting dangerously, more likely towards themselves than they are others. So it might be that you need the assistance of trained mental health first aiders, so like with our mental wellbeing first aiders, or people trained in physical health, or it might be that you want to get local NHS services. What I would recommend at this point is the Hub of Hope is a really good app because it's across the country there of services that you can offer. And then there's some charities here as well, which you can, this will all be in your handout, so I won't go through those ones. Or it might be that they're part of a crisis team or a community mental health team or social services as part of the Mental Health Act as well. But people don't realise that they can actually take somebody in a mental health emergency to A&E. So that's really important to know as well. And then finally, as part of the ACT plan, is to talk. So just offloading with somebody who's caring and who's listening can help somebody feel calmer and lighter. So don't underestimate the power of a conversation, and lead that conversation with empathy. So there's some examples here, gosh, that sounds really tough. Rather than trying to fix, you want to help the person open up more. And I think I'm up for time now, so I will not play my video, but I'll send you a link afterwards if you want to watch. It's just a 2-minute video on explaining empathy a bit more. But what I've covered today there on the screen, and if you want to connect with me on LinkedIn, my QR code's there, but equally it'll be in the handout as well. And if you want to reach out we've got like a free 45-minute training that you can access as well if you want to share that across your team as well. So I will stop there. Thank you everybody for listening, and I will stop sharing to hand over back to Monica. Thank you.
Thank you so much, Tracy, and thank you for managing to do that in the slightly condensed time that we asked you to. It was absolutely full of top tips and further resources that we can go and explore afterwards. So we'll make sure that those are shared along with the slides for the webinar. And I also think a really helpful reminder of the importance of recognizing those signs and symptoms among ourselves as we try and support, as well as recognize them in the people that we're supporting with. And that's actually so important to remember and recognize. So yeah, really, really powerful presentation. Thank you, Tracy. We're going to move on to Sarah now. Welcome, Sarah. It's great to have you on this webinar. Sarah was actually the lead of the National Green Social Prescribing Extension Evaluation Project for Nottingham, which was a project that NASP were involved in as part of her role in Nottingham Community and Voluntary Service. And she played a role in developing the mental health levels that she's going to be speaking about today. So Sarah, over to you. Do take us through those different levels.
Brilliant. Thank you so much, Monica. It's wonderful to be here. Yes, I'm excited to share a bit about the work that I've been part of, developing the mental health levels. I'm Sarah Payne, the Strategic Collaborative Lead at Nottingham CVS, an organisation that supports local voluntary community organisations. Have been doing so since 1875. So we've just been celebrating 150th birthday, sharing all the ways that we've strengthened, championed and supported our sector through advice, training, volunteering and partnership working. And if you want to find out more about us, you can visit nottinghamcvs.co.uk. So without further ado, we really wanted to support the referral pathway. And in speaking with social prescribing link workers, they highlighted a common challenge. That was, how do we know whether an organisation can support someone's level of need before making a referral? So we were really hearing in various ways that a more informed decision-making process at that early stage of a referral was required or would be useful. So this is where the mental health levels were developed to support that clearer communication between health and VCSE sector, to also support a description around what those activity providers in the community can offer someone who is wanting to look and engage with their activity, what support was already available, what support they might need to bring. Which then in turn also helped to identify appropriate starting points for engagement. So what sort of questions they might need to ask that organisation in order for them to feel confident in engaging in their offer. So let's break this down a little bit more, partly from the perspective of someone experiencing different levels of mental health or ill health, as Tracy's helpfully described. And we've kind of grouped these a little bit in relation to what an organisation might be able to deliver in terms of that level of support to meet those level of needs. So, from someone who is very proactive, able to self refer and make their way to an organisation, so they're feeling quite proactive in there and staying well, so they've got good mental health, right through to perhaps that early support where they know that engaging will keep their mental health strong. Perhaps they've found, they've started seeing some of those signs that have just been described, and they're wanting to kind of support their mental health more because they've noticed this emerging need. Right through to those much complex, perhaps they've just been engaging in crisis support within statutory services and are wanting to actually move that transition into kind of community offers and would still need something quite intensive or tailored intervention in order to feel really confident to do that. So if we then take that kind of concept of these levels from the person perspective to the organisation, this is how we would describe it in terms of most groups within the community offer that kind of level 0 to level 2. So what do I mean by that? They may be able to offer kind of opportunities where it's self-directed. You can just turn up, but they're big groups, it might be large events. You know that type of activity, if you are struggling with your confidence, your mental health at the time, that you might need to go with someone to support you. And so that is what this is about. If we could get a real sense of that kind of ratio of facilitator and participant, I would then, as someone exploring that option, be able to know I need to bring someone with me, or I would be held by that organisation, how they're delivering that activity. Because there are groups that can support people very specifically. And not many people also know that there's this enhanced support and specialist support in the community. And some of them are actually linking to NHS services in order to support that kind of transition from that intervention that they may have accessed in the NHS into their local community, but remaining very supported in order to do that. So there's a real range, and by having these levels, we're hoping to support that communication and understanding of that range and diversity, but also help with that conversation earlier on. So the framework really, we want to kind of, in a summary, really want to help support that communication of what services offer. We want it to enable safer referral decisions by asking those questions much earlier on around what it is that they may need in order to engage with those activities, and provide a bit of a shared language between health and the community sector, as well as managing those expectations from the referrer and all the potential participant, particularly participant really, to know that a certain level of support will be available or not available to them, and therefore they might need to come with that support. So what it isn't, it's not a way of labeling people. We're not here to say you are X and therefore you can only access a level 2 activity in the community. No. A person may well access something at a level 4 and a level 1 at the same time, and that's absolutely fine. They know that at the level 4, they're going to engage in a one-to-one or very small group, be very well held, and perhaps they can do that confidently on their own. Whereas when they access that level 1 or 0 group, they might be thinking, I need to take my family or friend or carer with me in order to be able to access that group, particularly initially, perhaps to build my confidence, get to know people, and feel safe. So it's not a rule that someone can't or can access more than one, but equally, it's also not a linear journey. We all know people are complex human beings, and therefore it's not about going, I've kind of engaged in something within NHS statutory support, and now I have to have a level 4 intervention. No, you might feel that following that that engagement, you can access something at a level 3 or a level 2, but you need to be setting up and ensuring that you've got that right level of support in place. Either you take it with you, or that that organisation has helped you kind of identify what would help you engage best to support you. So, as a referrer, you'd be having these conversations, and you may also be helping that person explore these options and know that it's not an indicator of an organisation's quality of delivery. So, an organisation may only offer those large, big events out in community, and they can't really source or have the capacity to support someone on a one-to-one when they engage with them. But equally, they could offer the whole range. And that doesn't, again, mean that they aren't doing that really well. That just means they've got the capacity and they've got the training and skills. And I'm hearing more around organisations wanting to, as a baseline, engage in training such as Tracy delivers around kind of first aid, mental health, in order to have that baseline support for people engaging. But it can vary, and it is worthwhile exploring what that organisation feels comfortable doing when supporting someone in their activities. And as link workers, you'll probably already know there's many factors around why someone may or may not engage in activities in the community. Their mental health can influence their kind of confidence, and whether they feel confident enough and might need that initial warm handover or support to engage initially. If they want to engage something at that perhaps lower level that offers some more social connections and skill working, but then they don't have that support network, they don't have a carer or friend or a loved one that can take and support them, therefore they might find it's not possible. Or the organisation might be able to offer something that enables them to do so. So these factors can really determine someone's ability to engage. And then you've got whether they're feeling they're able to do it that day, activities that help them most, and those logistical factors, which I'm sure you've come across a lot around the location. Is it close by? Have they got to travel? And what time is it on in that day? So all these factors play a part. And the reason we chose mental health was because it is one of the most common referral reasons we found within social prescribing. And it also is quite a broad, as we've seen, kind of category. And a lot of the community providers offer holistic well-being. And so they're able to kind of meet various levels of that mental health and mental ill health. And so as our sector, we're very diverse. We can support with that connection through creativity, nature, meaningful movement, and heritage. And so this tool really just helps with that clarification around the boundaries that an organisation has in the level of support they can offer, but also encourage that collaboration, ask those important questions at the start as to what could be put in place in order to support someone to engage in something they've found they would like to start attending. And we've also embedded these in directories. So this framework can be used in relation to a directory to help with those very early conversations. So in summary, it's a great way to kind of, well, at least a starting point to help with health systems, community organisations communicate around this topic, and support that referral pathway earlier on and guide people towards that appropriate support. But we are aware it's not just the one only tool that can support more joined up care. So we've got examples, and there'll be a link in the chat with reference to where you can find the Big Green Book and the Travel Well. So these directories have embedded the framework, the mental health framework in the Big Green Book, and has been adopted in the Travel Well. So it's a great way. There's lots of ways of embedding this framework. If you'd like to find out more or speak with me or share this webinar, then please do. And my contact details are on here. Thank you so much for having me, and I can't wait to hear from the next speaker.
Thank you so much, Sarah. That was really interesting. I'm definitely going to go back and reflect on those levels. And I think, as you kind of described, it though developed through the Green Social Prescribing Program, there's actually loads of scope for this to be used in a much broader way, to have that common language between link workers or other professionals and those activities that they're referring into, in order to be able to sort of fully support those the people that they're trying to support. And yeah, thank you for providing such a detailed overview of it. I think we have got a link to that on the NAS website, and all of those links that Sarah has shared, we will make sure that those are shared alongside the slides and the recording as well. Do pop any questions into the Q&A for all of our speakers, and we'll come to those after we have heard from our final speaker, who is Ashwini. So Ashwini, it's really great to have you here. Ashwini is a mental health social prescribing link worker who's been working in a GP practice in Peterborough for 4 years. So Ashwini has used the concept of social prescription actually towards her own wellbeing journey many years ago, before link worker roles were formally created, and therefore strongly believes in the process, and now really champions it in part through our link worker advisory group here at NASP. So welcome, Ashwini. Looking forward to hearing from you.
Thanks, Monica. And I will just shut my camera for a few minutes because I wouldn't want to see myself and the content. So please bear with me. Right. So I'm Ashwini and I'm a mental health social prescriber. And today I'll be talking about the role of social prescription in supporting mental health and well-being. So we all have our own reasons for joining any profession, and my reason for joining this profession is my own journey with my battle of cancer. I won't focus on the physical symptoms because we all know how difficult the journey of cancer is, but psychologically, how it left me was quite enlightening for me, because I had to give up my work, and that kept on giving me a feeling of isolation, that everyone is going ahead in their life. I'm stuck. Used to feel very angry and frustrated, feel stressed, depressed, and stuck, like, and I didn't want to, felt like I don't want to carry on. So at that point, once I got better, after that, upon reflection, I used to reflect a lot. I'm a very reflective person. So I realized what the meaning of vulnerability truly is, and how important active listening is, because there were some very lovely people who supported me towards my own well-being. And then I understood what the concept of active listening is. And I also understood that there is always a struggle for some people to engage. It's not that they don't want to, but there can be barriers why they want, despite wanting, they are not able to engage. Then I decided to change my background from human resources to the social sector. And since 10 years now, I have been working in the social sectors, and now I'm a mental health social prescriber and thoroughly enjoy it. So in the mental health social prescription, the typical needs, what we identify, come across as you would have done so as well, is loneliness, isolation, depression, anxiety, etc. And the ideal intervention, what we talk about, that if you see someone who is lonely and isolated, then signpost them or refer them for befriending services. Someone who is anxious, talking therapies can be good for them. However, you would have noticed that does it work that straightforward way when you are dealing in with the cohort of mental health patients? What I would be talking here about my experience and my learning journey. So what I realized was it was not that straightforward for me. So I reflected on why am I finding it difficult that if the patient who is feeling isolated should be connected to befriending services, then why am I finding it difficult for a patient to engage? So there has to be something different. And what is different when we are dealing with this particular cohort of mental health? So the thing is, we are here dealing with complex needs. Patients who are I would say instead of clients, I'm saying patients because I am based at a GP practice. So by default, the word I use is patients. So the patients who I see mainly have gone through a lot in their lives, childhood trauma, sexual abuse. So these are the kind of things which you cannot just fix in one appointment, or you cannot just fix with, they have already seen so much that so many of them may also have lost trust in the system. They would have decided that they don't want to talk to anyone. And so many of them would have gone for, like, substance abuse, because at that time they would have felt this is the best way to cope. So this is one of the barriers that doesn't help for the patients to engage. In addition, there are other barriers like those who have already seen so much in life. It is very normal for people to feel socially anxious. And if you're seeing, and if they're feeling isolated and we refer them for befriending services, they may not want to. If they are going through complex trauma, they may not want to revisit their trauma by speaking. So these are another types of barriers, or severe addiction. It is very difficult for a person who is going through addiction to fix the addiction over few appointments. So these things are they add another layer of barriers. Then we talk about operational level barriers. Like when I started my role 4 years ago, there was lack of awareness about my role. And within the GP surgery, everyone else was in the clinical setup, and I was in the only one in the social setup. So it took me time to understand others, and others took time to understand me. So at that time, the role was not integrated within the practice. So I had to work towards it to make people aware of what I do. And the boundaries of the role were not clear, neither for them, not for me, because the role itself was new. And now, 4 years hence, we are much more clearer about what we do. And I'm much more integrated. And I'm going to share with you the toolkit that I used. From the patient's point of view, the role was new, so they did not know what a social prescriber does. And so many people used to call me a social describer. Some people used to think I would prescribe a medication. Initially, I felt that when I would give them a call, as a marketing agent, I'm selling them social prescription. But then I felt this is not something right. I shouldn't be doing this. Um, then some people used to think I'm a form filler. So it's like, if you can't fix my problems, then you are not doing the job. So this led me towards the feeling of confusion and self-doubt. Can I quickly ask if anyone else goes through this? If you are a mental health social prescriber, if you can quickly say yes or no in the chat window, that will be great. And then, great, yeah. So I thought, then if this is supposed to work, theory, why is it not working? Then am I doing something wrong? Why are patients not engaging? That means that I need to do something different. Then this was again a process of my evolution. So this is the toolkit that I used based on, this is not, I mean, everyone has got their own learning process. And this was basically my own learning process. And you all will have your own learning process. I did not hesitate to ask questions. So what I did was, we have a practice manager who is very experienced. We have very experienced GP partners. I would just go to them and ask, what do you think? Because they have seen patients for so long, so they understand everything about the patient. So what do you think? What can be the barrier for this patient? So I would encourage you, wherever you are unsure, don't hesitate to ask questions. I used to present in the team meetings, in the multidisciplinary team meetings or clinical governance meetings. And the more I presented, more I could talk about the barriers that I was experiencing. When I joined NASP, that was the best thing, because I could talk to the other link workers, and I could see that those who were dealing in the same with the same cohort of mental health, they were going through the same kinds of feelings. So this gave me peer support that I'm not the only one who is going through this. So then it gave me that sense of confidence that, okay, this is like I'm building on it, and I'm learning through my colleagues, and I'm building on that confidence. Then I also learned that there will be some patients who will have very complex needs, like who are actively suicidal. And it is important to immediately raise safeguarding and tell them about, get your colleagues involved, get your GPs involved, and also tell about the emergency numbers. These are very, very important things to always remember. So I could then gradually see the transformation that earlier, during the first time, I thought that I would fix all the problems for the patient. Two, then slowly I understood that I can't solve all the problems, but it is about taking one step towards addressing what is important for the patient, and then building from there. And now I am in a position where I can say that social prescribing, it does work, but it is a slow process. And it may be invisible immediately, but it is important to generate awareness about it. There are practical hurdles, but it is also important to take patient feedback and also share the feedback with people so they know that it does work, and encourage people. A quick case study for that is like I saw a patient who had a history of domestic violence and social anxiety. And when the patient was followed up regularly, it helped build her confidence. And I could see that slowly she started engaging with services because of that confidence given to her that someone is there for the patient and she is listened to. So thank you. Um, so that is it. That is, and I'll leave you to any questions, and I will hand it over to Monica again.
Thank you so much, Ashwini. I can just see from the chat how validating your presentation has been, as many of the attendees that we've got here today have resonated with the experiences that you've had. So thank you so much for your openness and your and for sharing your own personal journey. And I think it's always important to recognise that the skills that we have as link workers don't just come from the formal training that we have, but also the personal experiences that we are bringing into the role. So you've articulated that really beautifully. So thank you so much for that. So we're going to move into a time for questions. So please do put any questions that you might have in the Q&A function. I can't see any in there at the moment, but I think I spotted one in the chat that perhaps Ashwini you could speak to, or Sarah, Tracy, if you've got any insight into this as well, please do feel free to come in. And that's from Helen, who has asked, what qualifications do you need to become a mental health social prescriber?
I do not think that you need any specific qualifications. So anyone can be a social prescriber. I basically had a background of dealing with people from vulnerable cohorts because I previously worked for it, but I don't believe that you need a particular social prescribing qualification to begin this career.
Yeah, I mean, it's something like mental health awareness. The training that Tracy has spoken to today is something that I would encourage all link workers to take on. I think that in terms of the specialism of mental health, I mean, the social prescribing link worker role is still relatively new, but that as a specialism is actually even more fresh. And so I think we're still learning exactly what those sort of skills and specialist training is most useful for the role. However, we do pick up in some of this in the training roadmap that NASP has developed, so we can also include that in the resources that are circulated here, and you can have a little look at some of those skills that might be helpful along these lines, and then help to map the local training that you've got available on those. So a question that came to my mind as I was listening to the presentation is around kind of link worker confidence. And Tracy, Sarah, Ashwin, I think you could probably all speak to this about how link workers can build their confidence in supporting people that they may identify through some of the tools that Tracy and Sarah have taken through are perhaps higher up on those levels of mental health. How would you encourage a link worker to build that confidence, either through training or through other means? Tracy, I don't know whether you perhaps wanted to come into that first, and then we can hand over to Ashwini.
Yes, sorry, I was reading questions. There's a question on there about what's the difference between mental health first aid and mental health social prescriber as well. So, sorry, what was your question, Monica? How would you improve your confidence in?
Yeah, so say somebody's quite new to all of this, a new link worker coming in and they're just starting to sort of support patients that they may have used these tools to identify
Yeah,
maybe a bit more severe on the mental health or experiencing mental ill health. How would they increase their confidence in those one-to-one consultations that they're having?
I think knowledge is power. So in terms of what you can train, but ultimately it's your skills in being able to listen effectively and try not to rescue everybody and have the confidence and knowing that just by somebody opening up and talking to you is already going to make a world of a difference. And the more you practice your listening skills, your active listening skills, the more confident you'll get at it. And then I always talk about like especially in the workplace, I'll say it's not your responsibility for that other person's well-being. However, we're responsible for if we have spotted the signs to have an intervention and have a conversation with them. Ultimately, that person is responsible for their own well-being, unless they're in crisis and you need to physically get them to somewhere. So it's how you can coach and encourage the person to be empowered to take action for themselves. And encouraging those signposts. So whether it's a social prescribing signposting or whether it's so trying to explain that difference as well between mental health first aid and mental health social subscribing. I guess for me, as in mental health first aid training, there's a lot of awareness around what's available in the workplace for you. So it might be that people have access to services like employee assistant programs like counselling and stuff via their workplace, which could skip NHS wait times and stuff. So it could get them immediate access. So it's connecting those dots. But ultimately, there's lots of connection there to national or local charities as well, which is why I'd really recommend getting to know the Hub of Hope app because you can actually, in those conversations, you can be getting the person to get the app on the phone themselves, and looking at services and finding the support themselves. Because I don't know about you, but if I've come up with the idea to do something for myself, I'm more likely to commit to it versus someone telling me to do it. So yeah, so knowledge is really key and building your education, but ultimately you're not there as a medical professional to diagnose. So you don't need to know too much. You don't need to know all the ins and outs and signs and symptoms of all the different anxiety disorders, as an example. You just need to know someone's showing signs and showing you that they're struggling with anxiety, and therefore you can point them in the right direction, and then you're signposting and you're helping them get the help. So try not to overwhelm yourself with trying to know too much and actually zone in on the empathic skills and the active listening skills. Things that like we should really be teaching at school, but we don't actively, someone said in the chat that they've done a counselling course. They're great skills to have, but it's being mindful that you're not a counsellor in that role and be mindful of the boundaries there. So yeah.
Yeah, and I completely agree. Making sure that you know the boundaries and the remit of your role and exactly what, and tapping into the other professionals that sit around you and really utilizing those that might have expertise in the areas, to make sure that you're not crossing any of those boundaries. And I think you made a really good point right at the beginning of your presentation, Tracy, of actually hopefully the time that we're spending together will boost that confidence in itself. And it is that, isn't it? It's interacting with others, conversing with others, not trying to take that responsibility purely on your own shoulders. Ashwini, did you have something to add to that?
Yeah, I mean, don't hesitate to ask. Like, I asked someone from Women's Aid that what do you do so that your patients engage? And she gave me such a lovely, insightful tip that she said that we all go through the trauma-informed approach training. And I took this back to the surgery, and all our staff got trained in that. And that was so helpful in communicating with the patients that the tools and techniques I still use now. So, we never know who can give us a good tip. So be open about the ideas. And at the same time, training. Eventbrite also has got such lovely training. So every small thing, it's like together along with time, and that helps.
Yeah, making the most of the resources that are available to you. There's a question in the Q&A just about who pays for the activity. Sarah, I don't know whether you can speak to that in terms of funding for the voluntary sector, perhaps. This question specifically asks whether social prescribing link workers have a budget.
I think.
Um,
Oh,
no,
no,
but
yeah, I was going to say, Ashwin, it varies, doesn't it? Actually, some surgeries I do hear that they are given a budget, but it doesn't help the fact that there is such variation. It's the same on both sides. So while some link worker teams may be given a budget, it's not quite minimal, but are given something for groups to sort of be set up and use because they've got quite a lot of clients all wanting the same sort of thing. But equally, in relation to the VCSE sector, so voluntary community social enterprise, they they're not consistently funded. So we do hear, and it is a barrier that someone may not be getting the right support in the community because they don't, the link worker doesn't want to have the conversation that this is something that's charged, and to kind of explore that they might charge, but equally they might have a pay scale. So they might be able to offer a discounted or a price that makes it accessible because often they do go for funding that helps them reduce the cost of their delivery. But equally, what I try and for sustainability, we try and have conversation costs because we're so very British about it. We don't ever want to talk money. So just to say that there may be costs associated, that there'll be support and to explore, but that may be a barrier for someone, and that equally has to be part of the decision-making process and be okay with that. As a link worker, you might find fantastic services, but not all of them may be accessible for financial reasons. But yes, but the unfortunately there isn't a one, they're all funded or not funded. It really varies in terms of being commission funded and all sorts of ways that an organisation may sustain their offer for people to access.
Thank you, Sarah. I know that was slightly off topic, but definitely related as obviously that can be a huge barrier for people accessing some of these services and sitting in the voluntary sector. I knew you'd have some insight into that. We're going to have to wrap that up. I know that's gone super quickly, hasn't it? That Q&A, and I wasn't able to kind of get to all of them, particularly those that came into the chat. So we will go back and reflect on those, and I'll just pop in an email address that you can get in touch with if you do have any burning questions that you feel have been unanswered, and we'll make sure we, as I said before, can share as many resources as possible. There should have just been a quick feedback thing that's popped up on your screen as well, by the way, so do fill that out. It will take you 30 seconds or so. And before we close, I just wanted to remind everybody that the best day of the year is coming up tomorrow, as it is Social Prescribing Day. So do take a look at our website, have a look at how you can get involved, use the hashtag Social Prescribing Day on social media channels, and let us know what you're getting up to. I'm really, really looking forward to it. And all that leads me to say is an absolutely massive thank you to all of our speakers and for everybody who's come and contributed through the chat today. It's felt like a really inspiring session, and I'm so grateful for all of the time that you've given towards it today. And also a thank you to Govinda and Audrey, who have been working in the background to help ensure that this is run as smoothly as possible. So thanks everybody, and see you next time.
thank you.
Thanks all. Take care.
Bye.